Joining us for this week's Your Health segment is Dr. Kelly Miller, interventional cardiologist at the University of Maryland, Baltimore, Washington Medical Center. Doctor, thank you for being with us.
Thank you for having me, Jeff.
We want to specialize, we want to focus on heart disease, leading killer of Americans.
Absolutely. So
people think of it as male, female. Is there any difference?
No, actually, many people think that the #1 killer of women is breast cancer. If you ask women, oftentimes they'll say, oh, my risk is breast cancer. Well, actually, it's heart disease. 1 in 3 women die of heart disease. And the incidence and the prevalence in men and women are a little bit different. So men tend to have their events a little bit earlier in life. And around the age of 50 to 60, that's sort of the peak incidence in a man. But women tend to lag about 10 years behind men in their risk of heart disease. And then by the time they develop heart disease, they have more comorbidities. You know, they have more kidney disease, they have more other vascular disease, they're older, they're frailer, and they actually tend to do worse. So it is not just a man's disease.
Symptoms differ at all?
So many people will say that, oh, women, they have totally different symptoms than a man. You know, a man, you think about an elephant sitting on your chest or crushing sternal chest pressure with shortness of breath and jaw pain and down the arm. And many patients will come to me and say, well, it was my right arm, so I didn't come to the doctors. I thought it was only my left arm, and that's not true. So either arm. Some people describe it as very severe indigestion. Sometimes it goes to the back and is often associated with feeling sweaty, feeling nauseated, cold and clammy. All these symptoms happen in women too. Okay, so women, sometimes don't have just the chest pain like the elephant on your chest, but they often do. And a lot of times they have chest pain and they kind of say, oh, it's not, I can't be at risk for heart disease. This isn't my heart. But in fact, it can be.
There are a whole bunch of factors that feed into making heart disease the #1 killer. What are the top ones? So
the things that you cannot change are you cannot change your age and you cannot change your family history. So having a strong family history, that is a first-degree relative, having a heart attack in a man before the age of 50 and a woman before the age of 60, that is a risk factor for heart disease. And when a patient comes to the office, nothing scares me more than them saying, my dad had a heart attack when he was 50 and my brother just had a heart attack and had stents put in. A strong family history is a very big risk factor. Age, certainly, the older we get, we can't change that. The older we get, the higher our risk of heart disease. But there are things you can change. So smoking is probably the #1 thing that you can change. If you are smoking, stop smoking. Ask your doctor to try to help you quit. There are many medications that we use to try to help people quit smoking. Physical inactivity is a risk factor. And then there are other risk factors such as hypertension or high blood pressure, high cholesterol, and diabetes. And diabetes is such a strong risk factor for heart disease that by the time a patient has had diabetes for about 10 years, it's not a question of do they have heart disease, it's how bad is their heart disease. So we need to treat patients with diabetes as aggressively as someone who already has established coronary artery disease.
Let's grab a phone call from Baltimore County. This is John. John, thank you for calling. Go ahead.
Yes, hello, doctor. I'm 80 years old, and I had bypass 6 years ago, and I'm doing fine up to this point. But then my doctor doesn't tell me anything. But she said I may have to have an angioplasty. Is that another operation?
Thank you for calling. So angioplasty is basically where we go in through either an artery in the wrist or an artery in the groin and put in small hollow tubes called catheters and inject X-ray dyes in your arteries, X-ray dye into your arteries, and see where the blockages are and how bad the blockages are. Now, you've probably already had a catheterization if you've undergone bypass surgery, because that's the first thing they do to determine how severe the heart disease is. And sometimes we treat it with stents, and sometimes we treat it with bypass, and sometimes we just treat it with medications. So if you have already had bypass, the likelihood is that if you are having symptoms of angina, and angina is just the word we use for cardiac chest pain, and sometimes angina is not chest pain or chest pressure, Could be shortness of breath with physical exertion. That could be a sign that your heart's not getting enough blood. So if you are now having a new symptom after bypass, then yes, you may indeed need further testing and a catheterization, and perhaps a cardiac stent would help you with your symptoms.
And interventional cardiologist, that's what you do?
That's what I do. So
okay.
I take care of people sort of both with stable coronary artery disease, like our caller, but also in the throes of a heart attack. So if somebody comes to the hospital having chest pain, having evidence that their heart muscle is not getting enough blood because there is a blocked heart artery, that's where I come in. So
you told me something interesting before, that your hospital is the closest to BWI Airport, and you get patients who have had heart attacks at the airport, and in many cases have been saved by the defibrillators that are scattered all through the terminal.
Yes. So about 1 in every 34 seconds, statistics say, someone has a heart attack in the United States. And I tell patients that a third of people don't make it to the hospital. It's not the heart attack that kills them, but it's the rhythm disturbance that accompanies the heart attack. Their heart goes into ventricular fibrillation, and that's what kills them. So a third of patients who have a heart attack don't make it to the hospital. They actually die in the field.
The heart hasn't stopped beating, it's beating incorrectly.
So it beats so fast that it's essentially not effectively circulating blood, and then there's no blood pressure, and then the patient dies. And that's where defibrillators come in. So the defibrillator can detect this abnormal heart rhythm and actually shock the patient to get them out of this abnormal heart rhythm and save their life.
And you need somebody who knows how to do it, but it's not hard to learn how to do it.
AEDs are not difficult to use. I mean, they're pretty much, there's a button, there's prompts, you just follow the prompts. So, if you're in a gym, if you're at the airport, a lot of schools, most schools will have them these days. I mean, they kind of tell you what to do. If you see a patient who has collapsed on the floor, call 911, and then number 2, locate the AED, and then begin CPR.
Interesting to think how many people might have been saved by the AEDs that were installed years ago at the airport over a long time span.
A lot. It happens not infrequently.
Let's take a phone call from Anne Arundel County. This is Greg. Greg, thanks for the call. Go ahead.
Yes, doctor. I'd like to ask you about the use of salt. I'm a 60-year-old man, and I use a lot of salt. My blood pressure usually runs about 110/70 to 120/80. I'm physically very active, and I just had a physical when I turned 60, and the only thing they found out is I have elevated cholesterol. Should I continue eating salt the way I've always been all my life, or should I cut down on that?
Greg, thank you. We'll get you an answer on the air. He's really hoping you're going to say have all the salt you want.
Actually, some people are very salt sensitive related to high blood pressure. So there are a lot of people who have high blood pressure who are very salt sensitive. If you have conditions such as congestive heart failure, you would be very salt sensitive potentially, and we certainly recommend not to add salt if you have congestive heart failure, and limit your intake of salt to no more than 2,000 milligrams per day. But changing your salt intake is probably not going to alter your cholesterol all that much. If your blood pressure is normal and you don't have heart failure, I would try to limit your salt to no more than 2,000 milligrams per day and read labels. But other than that, it's okay, I think, a little bit to salt your food.
Let's focus on exercise a little bit. Certainly you want to see more physical activity. Some people maybe get older, are concerned that could precipitate a heart attack instead of helping to prevent one.
Yes. So I think before beginning an exercise program, it's important to speak with your doctor. So to identify your personal risk of coronary artery disease, because you may be at higher risk than you think you are. So, age, blood pressure, cholesterol, diabetes, all these things need to be looked at to individualize your medical treatment. And then if you want to start an exercise program, sometimes we do recommend that we actually do a treadmill stress test in the office and see what you can do and what your exercise capacity is, and from that point forward, direct your exercise a little bit better.
Are there different types of stress tests in terms of how difficult, how invasive?
So the most common type of a stress test is just a run on the treadmill and watch your EKG type of stress test. But there For some people who cannot exercise or some people who have abnormal EKGs to start with, that's not the best test. Sometimes we use a chemical to simulate exercise or basically open up the blood vessels, and we give them a radioactive tracer that goes where the blood flow goes. And then we take pictures of the heart and compare the pictures at rest and with stress. So that's called an exercise nuclear stress test or a chemical stress test, nuclear stress test.
Let's grab one more phone call from Montgomery County. This is Ken. Thank you for the call. Go ahead.
Hi. Yeah, I have mitral valve prolapse with significant regurgitation, and I've heard about minimally invasive valve replacement. What can you tell me about that, or my possibilities for that?
We'll get you an answer. Good luck, Ken. Thank you.
So it kind of depends on a lot of factors. I mean, probably minimally invasive mitral valve replacement is not ready for prime time in a patient who is otherwise a good surgical candidate. And the same goes for, actually, I know you've had Dr. Brad Taylor on the show before. We talked about trans-aortic catheter-based valve replacement. Probably for someone who's a good surgical candidate otherwise, a traditional surgery is probably their best option. But, you know, if there are risk factors that make you too high risk for surgery, then that may be an option.
Very good. Dr. Kelly Miller is an interventional cardiologist at the University of Maryland's Baltimore, Washington Medical Center. Thank you for coming in.
Thank you for having me.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.